Dr. Rajiv Agarwal is here. Sir, good evening.
Dr. Piyush has also joined.
Yeah. Dr. Piyush.
Good evening.
Good evening and welcome.
Thank you.
Dr. Rajiv Agarwal is here. Sir, good evening.
Dr. Rajiv, good evening. Dr. Piyush has also joined.
Yeah. Dr. Piyush.
Good evening.
Good evening and welcome.
Thank you.
Dr. Rajiv Agarwal is here. Why is there a...
No. It's okay. Done. Done.
Okay.
So I think only Vedant hasn't joined. So
Vedant, Shubham.
Vedant and Shubham. Yeah.
Yeah, I've spoken to both of them. They're joining.
Shubham has joined.
Okay.
Hi Shubham, how are you?
Hi, sir. Good evening.
Hi, good evening, Dr. Shubham.
Good evening, Dr. Vishali. How are you?
I'm good. Thank you. Thanks for joining.
Yeah.
We're going to wait for another 2-3 minutes before Dr. Vedant joins, and then we'll start. All right?
Sure.
Yeah.
Hello. I'm just coming.
Okay, Vedant is here. Hello, Dr. Vedant. Welcome.
Hello, Dr. Arun. Thank you.
Hi. Hi, Dr. Vedant.
Hi, Dr. Vaishali.
Yeah. So now that all the faculty members have joined and we have a good participation, I think we should start. Dr. Goel?
We should start.
Yeah.
Yeah, I'll start. Hello. Very good evening to all of you. On behalf of Indian Anti-Cancer Trust, under the banner that we organize these events, focus studies in breast cancer. We have been having 2 weekly events. Only thing is we missed one event 2 weeks ago because we were a little late in planning. I hope that we do not have such gaps in future, but definitely it's nice to be back. So I'd like to welcome all the faculty and all the people who are who've tuned in to listen to the discussions today for this event. And without wasting any further time, I would hand over to Dr. Vaishali Zambre, my colleague, to introduce today's event and get the ball rolling. Dr. Vaishali.
Thank you, sir. So we have chosen the topic of DCIS for today's webinar, and we thought who else but Dr. Sandeep Mathur and Dr. Vedant to give us the pathological and surgical perspective of DCIS. So the first speaker is going to be Dr. Sandeep Mathur, who is a professor of pathology at All India Institute of Medical Science. Dr. Vedant Kabra is the head of surgical oncology at Manipal Hospital in Delhi. So to begin with, I would invite Dr. Sandeep Mathur to take us through the pathological aspects of DCIS. Over to you, Dr. Sandeep.
Thank you, Dr. Vaishali, and a very good evening to all those who have gathered here today. And I'll start by sharing my screen first. Okay. The screen is visible now?
Yes, yes.
Okay, thank you. So today in the next 20 minutes or so, I'll be talking about the pathological spectrum of ductal carcinoma. Just a minute, I'll minimize the screen. So pathological spectrum of DCIS and its clinical correlation. That was what I was asked to speak upon today. Now, this is a very, very important topic with which we as pathologists are more often encountering these days as compared to what I probably used to see, say, around 15 years ago when I was in my early career or as a senior resident. We hardly used to get to see these kind of lesions. But now, with the courtesy of radiologists and very good biopsy techniques, which our surgeons and the radiologists have evolved, we are getting to more often see these lesions, and really these are challenging lesions. And it's not wrong to say that in our country there is very limited experience with these lesions, because this screen detected lesions are being detected of late in more proportions, and only most of the centers with high throughput breast biopsies, I mean high volume breast biopsies being done, they are having enough experience to interpret these. So I will now take you through the spectrum of diseases. Now, as I said, that this is increased detection of these so-called atypical ductal proliferations with the increasing mammographic screening. Now, these atypical proliferations, they range from lesions which have a very low risk to high risk. So, and the guidelines regarding the management are also not very unequivocal. I mean, there is a gray zone depending on the patient characteristics, the characteristics of the lesion, the institute practices and practices of the surgeon, etc. So a lot of variables are there which kind of alter your management from the standard guidelines. And pathologists in this process play a very key role, not only in the first diagnosis, but also in following up these lesions. So I'll today cover the spectrum of atypical ductal proliferation. I'll be coming to these terms which I have enlisted here. Some more details about ductal carcinoma in Situ, its definition, classification, the radiological features, clinical features, what kind of diagnostic tissue is important, and then the entire gamut of these pathological spectrum of DCIS, the various biomarkers which may be important in this, and how we report these kind of lesions. So before I go to that, just a brief introduction about the breast anatomy from a pathologist perspective. If you see, most of the lesions which we see in our day-to-day practice, they emerge from this, which is known as the terminal duct lobular unit. So these are the lobules and the terminal ducts. So these are the origin of almost all significant pathologies affecting the breast. And the central dogma for pathologists is this, that there is a duct which has a basement membrane, and then there is a dual layered epithelium. One is the luminal aspect, which is the luminal epithelial cells, and then you have this blue colored is the myoepithelial cells. Now, whenever there is a evaluation of a breast lesion, we look at this, whether there is a breach of basement membrane or the loss of myoepithelial cells. These are the significant features. Now, whenever there is a proliferation, it is an admixture of, in the normal proliferation, it's an admixture of luminal epithelial cells and myoepithelial cells, which can be detected by specific markers. And this proliferation, when it is clonal, it is considered atypical, and thereby there are certain morphological and architectural characteristics by which we call them as atypical. So a very simplistic way to look at it is like this, that there are ductal cells, there is a usual hyperplasia, there is a ductal carcinoma in situ, and when it breaches the basement membrane like this, then there is a invasive carcinoma. Now, what are the preoperative diagnostic modalities? Definitely in case of DCIS and the screen detected lesions, there is only one, which is a core needle biopsy. This is the modality of choice, although even this has its inherent limitations, depending on the quality of the biopsy and how it has been handled in the lab. FNAC I brought out here because people I've seen reporting DCIS, ADH, etc. on FNAC, which to my mind is completely wrong. It should not be practiced. FNAC has no role practically in these pre-neoplastic lesions. Now, regarding the size of the biopsies, it's preferable to have very large cores rather than multiple. So kindly do not divide the cores for some other purposes like research or sending into another center for diagnosis. That will kind of, not be a very good idea as far as the accurate assessment of that biopsy is concerned. So the spatial organization has to be preserved. Architectural fraying of intraductal lesions can lead to complete disasters in interpretation. Usually vacuum assisted devices, they yield larger cores, and in small lesions, they may also be curative. And of course, these are the standard must do for any specimen, proper labeling. And in case context of these lesions, which I'm going to talk about, we need to know, especially the specimen radiography it has been done, or the pre-op mammograph correlations and correlations with the calcification. So you can ink or submit these calcified biopsies which have been taken from the calcified areas in separate bottles and label them as such so that we know. So ensure adequacies and whether the biopsy is really valid is that specimen radiography. Now this slide highlights that point, that you can see this is a specimen radiograph. These are the calcified spots which are seen in this. So this indicates that this biopsy has been taken properly. Now the type of calcification will also matter. So you may have a lesion which has benign calcification as well as this significant calcifications, which the radiologists call them significant of a DCIS. So the level of sectioning, plane of sectioning is also important. So to say that there is no DCIS or a DCIS, your level of section should reach the significant calcified area. Okay, so that's why if this plane of sectioning is superficial, you may miss this underlying more significant lesion. That's the importance of specimen radiography. There always has to be a radiohisto correlation, but there will be some lesions which have borderline findings like ADH, lobular neoplasm, radial scar, papillary lesions. So these are the lesions which require complete removal. You cannot really finally comment upon this. Now coming exactly to these lesions, they are the intraductal proliferative lesions. There is a whole spectrum ranging from benign like usual ductal hyperplasias, columnar cell lesions, atypical ductal hyperplasias, and DCIS. UDH does not have its relative risk is only around 1.5 to 2 times as compared to a normal population. But this risk may double if you have a family history. So it kind of creates a fertile ground for atypical regions to occur. UDH is nothing but increase in the number of luminal epithelial cell layers. We characterize them as mild, moderate, or florid when it is filling up the entire duct. So this is something pathological. The more important part is how we call this UDH. Now remember, because this is the gray zone. Many a times biopsies are taken in patients with fibrocystic disease who have tremendous usual ductal hyperplasia. Now this is the area of confusion where people end up calling them as ADH or DCIS. So that's why I've highlighted certain models. So there are morphological, architectural, and immunohistochemistry which we use to characterize whether it is a usual, which is a benign of no significance, practically no significance, or whether it is a significant one. So when you get these irregular slit-like spaces in atypical proliferation, you get rounded spaces. Here you get these the empty spaces which you see are irregular slit-like. There is nuclei are not monotonous. They show an isonucleasis. That means variation in size. Some are large, some are small. Then Some more, this figure also showing split-like spaces. Then these papillae are pointed, broad-based and narrow tip. So this kind of a micropapillae with a broad base is also in favor of a usual hyperplasia. Then any kind of metaplasia like squamous metaplasia or apocrine metaplasia, that is also a feature of a usual ductal hyperplasia. Then this kind of a streaming or nuclei aligned in one particular direction, grooving of nuclei, these are subtle pointers. So this, see, this duct is entirely filled up with epithelial proliferation. For the novice, this may be a very, is it a ADH, is it a DCIS kind of a lesion? So one is morphology. Second is use of immunohistochemistry. So you use typically two markers. One is estrogen receptor and a CK5/6. Now the usual hyperplasias, they are an interplay of epithelial and myoepithelial proliferation. So CK5/6 is a myoepithelial marker which is retained in usual hyperplasia. So this is a one marker which helps. Other marker which helps is ER, estrogen receptor is heterogeneous. That means not, as you can see in this figure, not all nuclei are stained by the estrogen receptors. Okay, so this kind of a patchy staining with ER is a feature of usual hyperplasia. That means this is not significant. Remember, usual hyperplasia is not confused with all types of DCIS. It is only confused with low-grade DCIS. The other spectrum you might be hearing these days a lot about is these columnar cell lesions, which includes just columnar cell change, hyperplasia, and there's one other entity known as flat epithelial atypia. These columnar cells are nothing but they are actually columnar in appearance, having a lot of apical snouting and some secretions within the lumen. When they are more in number of layers, more than 2 layers, it is called as columnar cell hyperplasia. These lesions also stain diffusely with estrogen receptor. So clinically, no further intervention is necessary if you have columnar alteration without atypia, or if the lesion has been completely retrieved. That means it was a small calcification and radiologic pathologic correlation has been achieved. There is nothing to do. FEA is low-grade monomorphic atypia, which is more closer to a low-grade DCIS. Here the nuclei are rounded, but because there are just 1 or 2 layers, it is a flat lesion. It is not hyperplastic. That's why it is known as a flat epithelial atypia. All these lesions which I talked about, the columnar and the FEA, they show strong expression of ER and PR. The implication is that they are frequently associated with low-grade DCIS, lobular neoplasia, and invasive tubular or lobular carcinomas. So a close follow-up is essential. So these were the now we're coming to more of the atypical ductal hyperplasias. Now, as by definition, it is a lesion with cytological and architectural feature of low-grade DCIS, but which is less developed in terms of architecture and degree of the lobular involvement and contiguous extent. So it's just a matter of the amount of involvement of the duct spaces and the number of ducts involved. So fewer than 2 duct spaces by one criteria by Page et al., and less than 2 millimeters in aggregate dimension by Tavasoli. So practically we use both or either of these to characterize a ADH. So ADH has these features which are similar to low-grade DCIs. That means they have these architecturally, they have these rigid bars, they have bulbous micropapillae. So the top is bulbous, the base is narrow, and they have rounded punched out spaces, as you can see here. The nuclei are monomorphic. That means as compared to normal benign proliferation here, which was pleomorphic, here it is more of a similar in size to each other. That means there is a monotony of nuclei. So it's a kind of a paradox.
Right.
Okay, so there is a partial involvement, as I already said, in ADH. When this involvement is more than 2 spaces or more than 2 millimeters, the same lesion we will call as a low grade. So if this is a duct, there are 3 duct spaces involved, this is a low grade DCIS because it is showing other features like punched out spaces, rounded spaces, monotony of nuclei. But if the same biopsy had only 2 such ducts, we would label that as a ADH and not a. So morphologically, they are both similar, just the quantitative difference. And as I told you, these atypical ductal hyperplasias and low grade DCIS, they show diffuse ER positivity and loss of CK5/6. Like in UDH, I showed that was present. Here it is lost, and ER is diffusely. So no patchy pattern. It is completely positive, and this is a very useful marker to characterize a lesion as ADH or DCIS. This ADH can involve papillary lesion, like in these 2 figures. It can involve apocrine adenosis. It can involve fibroadenomas like in these two figures. It can involve sclerosing lesions. So all other benign lesions of the breast can also be involved by ADH or a DCIS. So what is the significance? There's a moderately increased risk for invasive carcinoma in ADH around 4 to 5 times without family history. And if there is family history, this risk rises to 8 to 10 times. So that's the importance. In a core needle biopsy, where there is a limited DCIS, they say that one should not overcall and be a little cautious about reporting it. What are the predictors of upgrade on a biopsy? If on radiology you see linear branching and granular calcifications, if the extent of ADH is more, and there are lower chances of DCIS if there are three or fewer terminal duct lobular units which are involved, and all mammographic calcifications were removed, and ADH with a micropapillary pattern is an indicator for upgrades of the lesion. This was found in this one particular studies. Now, around 20 to 65% of ADH can be upgraded to a carcinoma or a DCIS, high-grade DCIS. So the current recommendation is to perform a surgical biopsy and remove all ADH or a VAB unless ADH is a single focus. Now coming to DCIS. DCIS, I already told you there are two components, low and high grade, and there is another intermediate grade DCIS. This low grade DCIS is more like a atypical ductal hyperplasia, whereas a high grade DCIS, as the word suggests, it has high grade nuclear features. They account for 25 to 30% of screen detected lesions, and 2 to 3% of such lesions can present as palpable masses. So early diagnosis is crucial to prevent development of invasive carcinoma. Now, we may say DCIS, but this is not, it's a kind of a unifying term for a heterogeneous entity based on the extent, morphology, the behavior and prognosis of these lesions. So, and when we say DCIS, it's a segmental disease arising from a TDLU, and it has a potential to progress right up to the nipple in the form of Paget's disease. So the proximal ducts may also be involved. Imaging is very characteristic. The calcified features is very important. The radiologist can really tell you what is the Birad's category based upon the calcification. But the extent of DCIS can be underestimated on mammography. And MRI has a limited role in DCIS. It can miss low-grade lesions. It is more sensitive in identifying high-grade lesions due to high vascularity. Now, these are some slides which my radiologist, Dr. Smriti, has given me. This is was a DCIS. You can see a cluster of microcalcification in the right central breast. This is the most common feature, microcalcification, and sometimes they can present as a simple mass or asymmetry without calcification. That is a non-calcified DCIS, but there is always a segmental ductal dilatation. And some ultrasound features are not very helpful, and MRI features pick up non-calcified DSA as well. So that's another significance. So as I told you, why I have just kept this table is not to go through it, but to tell you that low-grade DCIS and ADH are very, very similar to each other. So it's just the quantitative difference. Low-grade DCIS has this monotonous nuclei, punched out spaces, calcification in the center. They strain diffusely and strongly positive for ER and PR. They can show this cribriforming pattern. Whereas high-grade DCIS, they show this central necrosis, nuclei which are pleomorphic, prominent nucleoli, and high-grade features I'll be showing in the subsequent. Usually we use these myoepithelial markers. You can see it has stained the periphery, but it is lost in the center. So that's a feature which is used to characterize a lesion as a. And this is a very good picture which shows the features of a high-grade DCIS. There is a necrosis in the center, which is when in abundance it is known as comedonecrosis, like in this. And then the nuclei are very pleomorphic, prominent nucleoli, brisk mitotic activity within the nuclei. Frequently, these high-grade DCIS are HER2/neu positive and show a high MIB1 proliferation index. Intermediate DCIS is somewhere in between, and intermediate like low-grade DCIS are also most often diffusely ER positive. So this slide just shows that such difference between the appearance of low-grade and a high-grade DCIS. As you can see, this sharp punched out spaces, monotony of nuclei, these are characteristic features, whereas in a high grade, the pleomorphism of the nuclei, prominent nucleoli, mitotic activity, and comedonecrosis are the features. We grade these on the basis of the nuclei, which I will not like to go through. This is more for the pathologist. And this is a comparison of how low, intermediate, and high grade DCIS would look like. See the monotony here, which is slightly lost here, but some of the features like punched out spaces are retained in intermediate grade. And in high grade, you see it's almost like a carcinoma, but confined within the ducts. Architecturally also, we like to classify them as comedo or non-comedon. So in the non-comedo, there are various patterns like papillary, micropapillary. When it fills up the entire duct, it is a solid. Here, you require E-cadherin staining to kind of differentiate it from lobular carcinoma in situ, and this is the comedo pattern. Paget's disease we call when it involves the epidermis like this. This is almost always associated with the underlying high-grade DCIS like you see in this image. So on core needle biopsy, the pathology report should include the nuclear grade, architectural types, presence or absence of necrosis, microcalcification, and this core needle biopsy DCIS is upgraded to invasive carcinoma on surgery in 15 to 36% of the patient, and on 10% that is lower with if you have earlier done a vacuum assisted biopsy, obviously because larger lesion has been removed. Now regarding grossing or pathological handling of DCIS, one must accurately assess the extent of DCIS. This is very important, and because mammography cannot accurately assess, the radiologist cannot accurately assess the DCIS. They can tell about the focality, but the extent is the domain of pathologists in millimeters. You will also like to specify how many blocks were there or slides were there with the DCIS, and how many blocks were actually evaluated. The margins are very important. I'll talk a little bit about that, and lymph node if they have been performed, sentinel lymph node. Now margin, positive margin, this is a very important thing. I think I'll exceed my time by a few minutes more. Is that okay?
Yes, Dr. Sandeep.
Okay. So a positive margin is an independent risk factor for tumor recurrence in multivariate analysis. Radiotherapy can decrease, but it does not nullify the risk of recurrence in patients with positive margins. So re-excision is definitely indicated in this scenario. We call negative margins in the current consensus is more than 2 millimeters, which significantly reduces the risk of ipsilateral recurrence. And a close negative margins who do not receive radiotherapy have a significant risk of recurrences. But keep that in mind that a negative margin does not guarantee the absence of a residual DCIS elsewhere. So this is a margin, DCIS on the inked margin, and this is a DCIS which is at a safe distance away from the margin. And on microscopy then, in the report, you should include the nuclear grade, the necrosis, whether it's comedo or punctate type of necrosis, because each of these has been correlated with the recurrence. Size or extent of the DCIS, margins, and calcifications. That means for correlating with the specimen X-ray and mammographic findings as well. So what is the risk? Finally, a summary of this risk assessment. There is a 4 to 5 times risk with atypical ductal, or I'm not talking about lobular hyperplasia today. High risk is that 8 to 10 times risk is with DCIS low grade, LCIS, and atypical ductal hyperplasia. Also, if there is a family history of breast cancer. And a very high grade risk in DCIS, high grade. So high grade DCIS carries but the precise level to differentiate from a low grade is really not known. Now regarding progression or the behavior, this was a very large and most elegant study on the natural history suggests that more than 50% of the patient with high grade DCIS have potential to progress to invasive carcinoma in less than 5 years if left untreated, while low grade also has a similar progression, but in a smaller percentage and over a more prolonged period. That's the only difference. Even this will recur, the low grade DCIS if left to. There's a lot of disagreement amongst the pathologists, and most often cause of this is not study, they just evaluated that. So there can be subjective differences in interpretation. I don't think I have the time to go through this today. One must always keep in mind that you have to differentiate a DCIS solid from a low grade, from a lobular lesion, and E-cadherin is the stain which helps you there. Regarding biomarkers, the ER is perhaps the only biomarker which has an established role. It is a predictor of response to endocrine therapy, but ER positive are also more likely to recur as invasive carcinoma in the long run. HER2 positive DCIS with high KS is usually seen in high grade DCIS. They are more often associated with local recurrences, and increased risk of non-invasive local recurrence and lower risk of invasive recurrence has been found in some studies. The molecular classification like we do for invasive breast carcinoma, the luminal types, the HER2 enriched basal type people have been doing in this, but there is currently no published significance, established significance of these molecular subtyping. Oncotype DX is perhaps the only one which has been established to predict a recurrence. So in those patients who can avoid adjuvant radiotherapy. So that's the only reliable, validated thing which is available. And lastly, I like to review this concept, which is the that when you have benign, this is the kind of a dualistic model of breast carcinoma. So you have two kind of spectrum, the low grade pathway and the high grade pathway. So this low grade pathway is more of an ER positive. They show gains of 16p, loss of 16q, 1q gains. Now these are the lesions, the columnar cell lesion, columnar cell hyperplasia, flat epithelial atypia. These go on to progress to atypical ductal hyperplasia, and they don't go on to develop high grade DCIS. They go on to develop low grade DCIS and breast carcinomas, which are probably the grade 1, the tubular carcinomas, the tubulolobular carcinomas, and some of them progress to grade 2 IDCs, the invasive ductal carcinomas. And the other end of the spectrum, which are the ER negative. So they are the high grade DCIS pathway. So they go through the high grade DCIS pathway, which can be further molecularly subtypes, and they can give rise to the subtypes like HER2 enriched, molecular apocrine, basal-like. So they have more of genetic instability and more mutations as compared to these. So this concept goes well. So you have low grade DCIS, which follows this pathway. And when there is loss of E-cadherin mutations, then you have this lobular lesions of the similar kind. Microinvasive, when the invasion is, you can see a DCIS here, the invasion is measuring less than 1 millimeter. So it has very good prognosis, and the chances of recurrence are very low. So they may be a treatment, drastic treatment may be avoided in these lesions. And never confuse this term extensive intraductal carcinoma we use in the context of resected specimen with invasive breast carcinoma when it occupies more than 24%. It is an independent prognostic factor for recurrences in invasive breast carcinoma. But the 25% which we talk about here is of course high grade DCIS. And regarding management, you are the experts in that, but I've just kept these NCCN guidelines. But my only highlight is that pathology review is very important, as NCCN has also highlighted here, along with radiology, of course, and ER is the only marker which they are talking about here, and I won't go into the details of the treatment. So finally, I'll conclude by saying that management of DCIS is a multidisciplinary effort. It is a biologically heterogeneous disease and has variable outcomes and ranges from indolent lesions like ADH and low grade to very aggressive forms like high grade DCIS. And there are no simple, well-validated markers or group of variables for risk estimation. The only clinically validated one I just talked about, the Oncotype DX. And with the mammographic screening and this detection of these lesions are increasing day by day. And accurate morphological assessment is very important by the pathologist. He can do judicious use of immunohistochemistry. And one must remember that even amongst pathologists, there is an inter-observer variability in the interpretation of these lesions. So I'll end my talk here. Thank you so much.
Yeah, thank you, Dr. Sandeep. Thanks for taking us through the entire gamut of different lesions like ADH and to low grade and high grade DCIS. I'm sure we are actually going to now have the surgical aspect of all this, whatever we have learned. So I would now invite Dr. Vedant Kabra to take us through the surgical aspects of DCIS. Over to you, Dr. Vedant.
Thank you, Dr. Vaishali and Dr. Goyal for inviting me for this. Let me share my screen and then we'll start.
Yes, it is visible now.
Okay, I'll just start the slideshow and
yeah.
Okay, so I've been asked to speak about surgical considerations only, and I believe Dr. Goyal is going to take up the medical oncology and radiation part in the panel discussion later on. As you see, the incidence of DCIS over the years has increased many times. And in fact, between these 2 years, these 20 years, it has nearly doubled. But if you see larger span, it has increased actually many times. And why has it happened? Because of screening mammograms, as Dr. Mehta also mentioned, almost 1 in 1,000 screening mammograms will detect DCIS. And if you have a mammographically detected breast cancer, more than 25% of them would ultimately prove to be DCIS only and not invasive cancers. Now, this is a non-obligatory precursor of invasive cancer. As Dr. Mehta also told you, even high-grade cancers, high-grade DCIS, only 50% or slightly over 50% would progress to invasive cancer. And if you take all the group of DCIS, then only 20 to 30% actually progress to invasive cancer. The range could be as less as 10, 15% to more than 50%. However, what we see is almost all of them are treated in the same way or a similar manner, because there is no definitive predictive tool which can guide us which DCIS to treat in what manner, where can we go a little more aggressive and where can we go for lesser or de-escalation of treatment. And that is probably the theme of this evening also. So there is a lot of scope of individualization to avoid under as well as over treatment in DCIS. Now, what do we have currently and what can we expect in future so that we can de-escalate or become more aggressive in treating DCIS? Diagnosing is mainly by imaging, and as we all know, 90% of them are seen on mammography. There is 8% which is seen on ultrasound only. And what is the role of MRI? Again, debatable. We know that MRI is going to show a slightly larger extent as compared to mammogram in many of the cases. And there are studies which support the use of MRI, and there are studies which say that it does not really help in decision making, just changes BCS to mastectomy unnecessarily. So we have to be very judicious in our use of MRI and preferably use it only for dense breasts, probably ACR grade C and D. There is diagnostic concordance or I should say discordance, which Dr. Mehta has already pointed out. It is much less when the diagnosis is IDC, but when it is DCIS, the discordance is 84, concordance is only 84%, and it can be over-interpretation or under-interpretation. You can interpret DCIS as IDC, atypia as DCIS, or DCIS as atypia. Now, coming to the treatment part, surgical treatment, there are lots of options available, ranging from no treatment to the other extreme, which is bilateral mastectomy. And the Angelina Jolie effect has actually changed the scenario, especially in US and many other countries. Sometimes we also face the Angelina Jolie effect and patients are asking for bilateral mastectomy for a unilateral cancer. So if you see the changing treatment pattern in the US, the SEER database from 91 to 2010 has shown a significant increase in lumpectomy with radiation. It's almost doubled from 24 to 47%. Increase in bilateral mastectomy, there were none seen in 91 for DCIS, but 8.5% patients underwent a bilateral mastectomy for a unilateral DCIS. No treatment from 1.2% to 3.2%. And as a result, there has been a significant decrease in unilateral mastectomies and lumpectomies only, because the use of radiation increased, and we have very good data to prove that radiation does help as far as local recurrences are concerned. So coming to the treatment, mastectomy is recommended for a multicentric or a diffuse involvement if a patient is unwilling or is unable to undergo radiation for some reason. It has a very low recurrence rate. So 10 years, the recurrence rates are only 1 to 2%, less than 2% actually. The other part is whether we do a simple mastectomy or a skin sparing mastectomy. In a carefully selected patient, skin sparing or even a nipple sparing mastectomy can be done, but be prepared for a higher local recurrence. And it was very nicely proven in an 8-year follow-up, local recurrence 0% with simple mastectomy and 5.6% with a skin sparing mastectomy. So we have to be really careful in choosing our patients. I very clearly remember a patient where we were doing a skin sparing mastectomy, but we found that a very gritty kind of sensation reaching almost up to the skin. We sent that for frozen and ultimately converted that into simple mastectomy. Breast conservation along with radiation is the standard of care. Currently, we do not have any indications where we can avoid radiation. There are 4 RCTs which have proven the role of radiation beyond doubt, and the local recurrences are decreased. A relative decrease is more than 50%. There is a consistent benefit shown, and all the trials have shown the same. There is a EBCTCG meta-analysis which was published in 2010, and again it showed there was an absolute reduction of ipsilateral breast tumor recurrence by 15.2%. So it reduced from 28 to 12.9, more than 50% relative reduction. Another RTOG trial which came in 2015 also showed similar results as far as local recurrence was concerned. However, such a big decrease in local recurrence has actually not translated into any overall survival benefit or breast cancer specific survival benefit. And same is true for hormone therapy as well. The other part of treatment is sentinel lymph node biopsy. We know that, and we usually practice for all mastectomy patients, we do sentinel lymph node biopsy in case the preoperative diagnosis is upgraded after the final specimen is sent. So we may not lose the opportunity to do sentinel lymph node biopsy, which still can be done by injecting into the subcutaneous space after mastectomy, but it is much less than the ideal situation. So all mastectomy for DCIS must be accompanied by sentinel lymph node biopsy. Now, if it is a bilateral mastectomy, we do only ipsilateral sentinel lymph node and not the opposite side, because the opposite side is essentially a prophylactic mastectomy. With BCS, do we do sentinel lymph node or we don't do it? Now, if you see the trials NSABP B17 and B24, the ipsilateral nodal recurrences were less than 1%. So we don't really need SLNB for BCS in cases of DCIS. And you must remember that lymphedema rates are not zero for sentinel lymph node. It is approximately 5%. So it is not negligible. There is a significant rate of lymphedema even after SLNB. However, the recommendations of ASCO are for a large tumor, which is more than 5 centimeters, because there is a high suspicion of invasive cancer. Post-surgery, you will find upgradation. If there is a mass lesion with clinico-radiological suspicion of invasion, and in cases of multicentric disease, and multicentric disease, most of the time we would go for mastectomy, unless there is a very discrete 2 different nodules which are still individually amenable for breast conservation surgery. The margins, Dr. Mehta again mentioned about it. What is the basis of that 2 mm margin? It was a meta-analysis done by MSK group involving 20 studies, and they showed that negative margins have significantly reduced the odds of local recurrence. And they also showed that there was no significant benefit beyond 2 mm free margin, but there was a benefit between 0 and 2 mm. So for IDC, we take no tumor on ink as a free margin, but for DCIS, it should be at least 2 mm. And as a result of this meta-analysis, all the associations gave in their guidelines that margin of at least 2 mm for DCIS should be there. And the individual discretion has to be exercised if you have a margin which is free but less than 2 mm, whether to re-excise that or not. So in case of a low-risk tumor, you may choose to observe, but by and large for a high-risk tumor, definitely you need to go in and revise the margin or convert that to mastectomy if that is indicated. However, there are certain situations where we do not know what extent of margin is required or is enough, because this group of patients, they're not very well represented in the literature. So a patient undergoing partial breast radiation, in a patient who refuses radiation but wants a lumpectomy, in multifocal DCIS, very large DCIS, and in younger patients, because these groups we still do not know if 2 mm margin would be adequate. So better to take slightly larger margin for such groups. Coming last to the last leg of my talk is surveillance. We have been talking about de-escalation and avoiding overtreatment. So can we have surveillance for DCIS, and which patients of DCIS can we keep under observation without any active treatment or without any active surgical treatment? As I said earlier also, if you increase the range of time, so from 1980 to 2007, the incidence of DCIS has increased by more than 7 times. And DCIS has always been treated. At least the recommendation has been there to treat it by surgery and then followed by radiation and also hormone. However, this treatment did not lead to decrease in incidence of invasive cancer. When we know that majority of them do not progress, still after treatment, you don't find any decrease in the incidence of invasive cancer. So because of the reason that majority do not progress, probably we see that there is no decrease in the incidence of invasive cancer. And there is a population-based data which has also shown that surgery may not offer significant survival benefits, especially in the low-risk group, and which has been further substantiated by a SEER data in the lowest risk group. So these patients who did not undergo surgery for whatever reason, they had grade 1 and 2 disease, hormone positive disease, and they were more than or 40 years of age. A 7.5-year cumulative risk of the incidence of ipsilateral invasive cancer in these patients who did not undergo any surgery after diagnosis of a low risk DCIS was only 5.9%, which is actually comparable with LCIS or ADH. And both these entities are only considered as risk factors for breast cancer. They are not considered as cancers that require surgery. So if you have a low grade DCIS, which has risk equivalent to LCIS or ADH, why do you treat them surgically? And that's the premise of having surveillance. There are 4 trials currently going on, 4 randomized trials: Loris, Comet, Lord, and Loretta. Loris is from UK, Comet is from US, Loretta is from Japan. And they have to have very close monitoring with treatment only on progression. Comet and Loretta, these 2 trials have also allowed endocrine therapy in the surveillance arm. So once we have the results of these trials, we'll have a very good mix of observation only versus the standard treatment. And we can also have a combination of observation, but with an option of giving endocrine therapy as well. And these are the 4 trials which are currently recruiting. Probably we'll have some results in next few years. Most of them have a active surveillance arm. As you can see, there is an endocrine therapy choice given for Comet and Loretta. The screening is with mammogram in most of them. Loretta has also allowed use of MRI for screening. Obviously, MRI can be used in other trials if the indications are there, and this screening is more intense. They will have to be subjected to screening every 6 months. All of them have included only nuclear grade 1 or 2, Lord including only grade 1. Comedonecrosis is a no for most of the trials. They have to be ER positive again in 2 of them. The other 2 have not specified, but they are probably going to take only low risk. The size of the DCIS has been defined in some of the trials to be 2.5 cm or less, and this is the group which has actually been shown to not progress much. So that is a low nuclear grade, ER positive, HER2 negative, and size up to 2.5 centimeter. And there is also international collaboration which is going to combine the data, and they are interacting with each other so that they can have a very good solid data for a proper recommendation of surveillance in a proper subset and carefully selected subset of patients. Apart from this, if you see the trade-off between the treatment and surveillance, the advantage that treatment gives is we are timely treating the patient. However, there is some disfigurement involved, especially if it is a mastectomy without reconstruction. There are certain complications of surgery, short-term as well as long-term, in form of neuropathy, shoulder dysfunction may happen. There are psychosocial effects because of disfigurement. And obviously, as we have seen in previous slides, there is an overtreatment. There is definitely a possibility of overtreatment. Versus surveillance, this obviously avoids any treatment related side effect, and which in many of the cases would be overtreatment also. However, at the same time, there are certain disadvantages because ongoing monitoring and very frequent monitoring does lead to some fear as well as anxiety in the minds of patients. Higher likelihood of mastectomy or needing chemotherapy, which would not be given if it is a pure DCIS operated right in the first place. And also radiation, because as Dr. Mehta pointed out, Oncotype DX DCIS score now is validated for avoiding radiation therapy. So these advantages and disadvantages, they have to be considered to make treatment decision, and they should be in accordance with an individual choice or a preference that the patient makes, and what are the goals for the patient. This surveillance also is very valid in those patients who are elderly, who have competing causes for mortality, and whose life expectancy is not beyond 10 years. They can definitely be put on surveillance. There are certain decision support tools also, and Comet study has developed one such tool, which is a chart showing the patient which can compare, and they can compare the risk and benefit of the treatment and the long-term outcome with each treatment option. And I'll just show one such chart, which is a very, very lucid chart. So within 10 years, out of 100 women who are diagnosed with DCIS and treated with lumpectomy only, 79 will not develop any invasive cancer or a recurrence of DCIS. Only 6 will develop invasive breast cancer. 7 may have a recurrence of DCIS. 7 of these 100 will die because of causes other than breast cancer. And only 1 woman is going to die of breast cancer. So if you show this chart and they have a low risk feature, they may decide to forego some treatment. And this is what is being made as part of the COMET trial. Going further step ahead, there is a precision initiative, and it stands for Prevent Ductal Carcinoma in Situ Invasive Overtreatment Now. This is a multinational collaborative effort by Netherlands, UK, and USA. They are doing preclinical, translational, as well as clinical research, and hopefully we'll have better understanding of DCIS after this precision initiative takes place and gives us results, which will optimize the treatment of DCIS, and especially, as the name also suggests, to prevent the overtreatment now, and it will help in de-escalation. So I would like to conclude by saying that DCIS is increasingly diagnosed. We obviously do not see the magnitude that is seen in the Western countries because we do not have a mass screening program in place. But all of us are now starting to see pure DCIS every now and then. Majority of these do not progress to invasive carcinoma, but still are treated almost like invasive carcinoma, apart from chemotherapy. There is a definite need for de-escalation, especially in the low-risk group, but we need to find out which those low-risk groups are who can be subjected to surveillance. And the surveillance trials, the 4 trials that I mentioned, are likely to provide some answers. It is going to take some time because the recruitment is very, very slow. And the other problem with recruitment here is, at least those trials which have offered endocrine therapy arm, patients are reluctant even to take endocrine therapy. There is enough data to show that even with a proven DCIS who undergo surgery, may undergo radiation, they are recommended endocrine therapy, but only 2/3 of them ultimately take up, and not all of them actually complete 5 years of endocrine therapy. There are molecular markers, gene risk scores, and the precision initiative, which is going to further enhance our understanding and partnering with patients to make treatment decisions, because they must understand what they are up to, what they are going to face in future, and let them decide after knowing the pros and cons. Thank you very much.
Thank you, Dr. Vedant. That was a very nice talk, as always. You covered the topic in great detail and gave important messages. So since we are going to have a lot of discussion in the panel now, so we'll proceed with the next talk. The next talk is by my colleague, Dr. Vaishali Zamre. She's a senior consultant in surgical oncology at Max Vaishali, and her primary area of work is breast oncology. So this talk is basically focusing on palpable DCIS. So as has been highlighted that in India, we generally see mostly symptomatic cases even now, while the West has a different profile and majority of cases are screen detected. So the purpose is just to highlight whether what we see from the background of symptomatic DCIS, and 90% of them are actually presenting as lumps. Should we think of it as a separate disease with a separate approach? So over to Dr. Vaishali.
Yeah, thank you, sir. Can you see my slides?
Not yet.
Okay. Now?
Yes.
Okay. So I welcome all the faculty members and the participants once again. And after Dr. Mathur's and Dr. Vedant's talk, wherein we had actually focused more on the risks of over-treatment. But in this issue, the palpable DCIS, we are actually worried about whether we are under-treating the patients, and majority of these patients are actually of younger age, and therein we are always worried about whether we are under-treating these patients. So I'm going to talk about palpable DCIS. As Dr. Arun Goyal has mentioned, we are going to see whether it is actually a different clinical entity and it should be treated in a different manner as compared to screen detected DCIS. Before the advent of, or before the mass screening actually became popular or came in existence, DCIS represented less than 1% of cases of breast cancer. And it was very simple. It used to be considered as a single disease, and the simplest way of treating it was mastectomy. And majority of the patients actually came to the clinicians with palpable masses or nipple discharge. But now that with the screening mammography in place, the incidence of DCIS has increased. At the same time, in our country, since we do not have mass screening mammography, we see nearly 20% of the cases which are actually coming to us in the form of symptomatic cases. And as we have seen in Dr. Mathur's talk as well, that it represents a heterogeneous disease. And obviously, whenever we see any patient with DCIS as in core needle biopsy, we have to actually think about the individualized management plan for this patient. So what is DCIS? As it has been described previously, the DCIS represents clonally proliferated epithelial cells, which are actually within the confines of the lumen of the mammary duct. And it is considered as an early step in the progression of invasive cancer. And since it is considered as an early step, we have to rationalize by the treatment by preventing the progression to invasive cancer and ultimately to prevent the breast cancer related death. So now we have to see whether these two different entities, that is the symptomatically presenting patients or screen detected DCIS, whether these are two different phenotypes or are these the parts of natural progression of screen detected variants. What we mean by this is whether we see a palpable or a symptomatic DCIS in the later part of screen detected variant, or does palpable DCIS represent a different evolutionary path, whether it takes a different path in terms of its evolution. That is what we are actually going to see. So generally symptomatic DCIS presents in the form of either palpable lump. So nearly 70 to 80% patients who are diagnosed with the symptomatic DCIS actually present in the form of a palpable lump. And some of them also present with Paget's disease of nipple or nipple discharge. So the palpable lump actually poses certain issues like, does it represent or does it have different pathological feature, or does it have a different radiological feature? Do we have some different management options, especially surgical or non-surgical? Or does untreated symptomatic DCIS differs in terms of its natural history from screen detected DCIS, or does it have any different prognosis? This is what actually I tried to look at the literature, and the majority of the literature which is available on this topic is actually retrospective, as we have seen that the prospective trials are difficult in this because of the low incidence of DCIS, and that too, palpable DCIS actually represents a very small fraction of DCIS. So when we say palpable DCIS, does it represent a high proliferative potential with low invasive potential? So when we say that the DCIS has presented in the form of a palpable lump, does that mean that although it has become palpable or although it has acquired certain dimension, it has a low invasive potential? So that is what actually some studies have actually tried to see. So I'm going to show some papers which have actually dealt into this topic. So the first literature which is available on this has come from Iran. It was actually published in 2015. So they have actually found 54 cases amongst 5,000 cases of breast cancer, which were actually retrospectively studied from 2004 to 2012. The mean age was 55 years and the mean tumor size was 3.8 centimeter. Of these 54 DCIS, palpable DCIS cases, 10 had multicentric tumors and 6 of them had lymph node involvement. And all of these were later on found to have microinvasive disease. So after the 2 to 8 years of follow-up, 4 patients had developed local recurrence and 1 of them had distant recurrence. So when they studied the IHC profile of these 54 patients, they found that, and this is quite interesting, actually this is a little different from the other studies, they have been found that nearly or slightly more than 50% of the patients were ER negative, as compared to the screen detected DCIs, wherein we find that these are actually low risk and majority of them are ER positive. This paper, actually, the authors have found that 51.8% patients were ER negative and 92.5% patients were actually HER2 positive. And the premise that majority of them were HER2 positive, that is what they actually, the authors have concluded, that probably the HER2 positivity actually gives them this high proliferative rate and low invasive potential. That is what they have actually concluded in this paper. So when we see the prevalence of cancer, these DCIs by cancer subtype, they have actually found that 50% of these 54 patients were actually HER2 positive. This is actually a little surprise because this is a bit different from the other papers. And when they found that majority of them were actually grade 3. So these grade 3 were actually found to be, majority of them were found to be HER2 positive and ER negative. And none of them have been found to be grade 1. So this is what actually they have found in this paper. And when they compared it with other studies which were actually published in 2006 and 2008, they found that in their study, a significant proportion of them were HER2 positive and luminal B, quite opposite to the other studies which were actually showing a large proportion of luminal A and HER2 negative. But they mentioned that these studies which have been actually published by Tamimi, Maginin and Levase, they were actually, majority of them were actually screen detected DCIS. So when they compared the clinico-pathological parameters in patients who had pure DCIS and DCIS with microinvasive disease, they found that the patients who amongst these palpable DCIS patients, those patients who had microinvasive cases, they were all high grade, had nodal involvement, and they were ER negative and HER2 positive. Now, I would actually move on to another paper actually, which was published from UK. It was published in 2014. And actually, you can see that 55% of these patients were actually presenting in the form of lump, and the others presented in the form of nipple discharge or Paget's disease. Then the median age was actually in palpable was slightly lesser compared to the screen detected, and 43% of these palpable tumors actually had invasive foci on the final histopathology. The median size was also a little larger compared to the screen detected cases, and lymph node involvement obviously was much more compared to the screen detected cases. The hormone receptor positive cases were 72%, quite contrary to those patients who were actually present, published in the Iranian study. But at the same time, it was lesser compared to the screen detected cases. And HER2 positive patients were seen in 15% of palpable tumors. And 64% were actually high grade compared to the 61% cases seen in screen detected. Then there was one study actually which was published from Singapore in 2015. This was again a retrospective data, and they had actually studied some 1,200 patients in the 16-year time frame, and of them nearly 50% were screen detected and similar were actually symptomatic. The median follow-up was definitely much more, actually 99 months, and the largest follow-up of some patients was actually to the tune of 246 months. So there, these authors actually found that the screen detected cases were smaller size, had low nuclear grade, and they were more frequently ER positive, and they were found to have better overall survival and disease-free survival compared to the symptomatic cases, which had actually larger size and high nuclear grades, and many of them were triple negative and HER2 positive phenotypes. And they also had cribriform and comedonecrosis was actually commonly seen in these patients, and some of them had invasive recurrences when they were actually followed up. And the recurrence patterns were actually seen in the form of either ipsilateral non-invasive recurrence, or ipsilateral IDC, or contralateral IDC, or some few patients also were found to have distant metastasis. Then this is actually a study which was actually presented in the form of an abstract from Tata Memorial Hospital. This actually is a retrospective analysis of data from 1998 to 2010, and they found that 71 patients actually presented in the form of palpable DCIS. Of them, nearly 50% had foci of microinvasion, and 51% were pure DCIS. The median age of presentation was definitely lower, actually 59 years, and the mean tumor size was 2.3 centimeter. So when they actually compared pure DCIS and DCIS with microinvasive foci, they found that the tumor size was more than 2 centimeter in 72% of the patients with pure DCIS, and it was 66% in DCIS with microinvasive foci. And the other parameters like nodal positivity was definitely a little higher in patients who had microinvasive foci. And amongst these, actually, 17 patients with microinvasive foci received chemotherapy, and 4 patients with pure DCIS for some reason also received chemotherapy in these cohort. So they concluded that, and then they obviously compared, the patients who presented with DCIS or DCISM with invasive ductal carcinoma with the size of tumor less than 2 centimeter, and they found that the disease-free survival in women with DCIS was 82%. As compared to DCIS with microinvasive foci, it was actually slightly lower to the tune of 78%. And on the contrary, the patients who actually presented with invasive ductal carcinoma but tumor size of less than 2 centimeter, the disease-free survival was actually 83%. And they concluded that probably these subtle differences are probably because of the use of chemotherapy in patients who had invasive ductal carcinoma. So they concluded that probably we need to consider the role of adjuvant chemotherapy in great detail in treating the women with palpable DCIS or those patients who actually present with DCIS with microinvasive foci. Now we would like to see whether imaging features are little different when we compare symptomatic versus screen detected. And when I went through the literature, I found that probably symptomatic DCIS patients present commonly with masses or in the form of architectural distortions, and they do commonly have accompanying ductal features. Calcifications may or may not be present in all the patients who present with palpable DCIS. On the contrary, majority of the screen detected DCIS actually presents in the major form of microcalcifications. And some literature also actually mentioned that probably palpable DCIS on imaging actually shows a larger extent compared to what is actually palpable. So this is our experience. So we in last 4 years, we actually found 6 cases who presented with palpable DCIS. And as you can see that majority of them were under 40, and one patient was actually of 50 years of age, and the tumor size ranged from 2.5 centimeter to 10 centimeter. And majority of them had actually core needle biopsy. Only one patient was actually operated with FNSC report, and 2 patients who had undergone wide local excision. One patient had actually mini LD flap, and she later actually found to have developed local recurrence. And one patient who had undergone wide local excision had margin positivity on paraffin section, and then she had to be actually operated immediately, and she underwent mastectomy. So these patients actually, all of them underwent sentinel node biopsy. The patient who actually had undergone wide local excision with LD flap was found to have invasion on her final histopathology. She was actually advised chemotherapy, but she refused chemotherapy and she took only radiation and tamoxifen. But 2 years down the line, she developed local recurrence and underwent mastectomy. And after mastectomy, she was actually found to have invasive disease. We actually had not been performing FISH in all the, HER2 testing in all the patients previously who actually had presented with DCIS. But nowadays we have started doing HER2 testing in all the patients. So we actually found that 4 patients were hormone receptor positive, and 2 of them were hormone receptor negative. And HER2 was actually done in only 1 patient, and that too it was equivocal, and she did not undergo FISH test, and we also did not actually insist at that time. But later on, she was found to have local recurrence. So to conclude, I would actually like to say that palpable DCIS is still an enigma, because this palpable DCIS actually represents a small fraction of overall breast cancer cases. We need a large prospective data to actually come to the conclusion that whether palpable DCI should be considered as a different clinical entity, and whether we should base our clinical decision based on whether the DCIS has actually presented in a palpable manner or in a screen detected manner. And at the same time, as Dr. Vedant also mentioned, that whenever a patient presents with palpable DCIS, we have to have a high level of suspicion of invasive component, and we should actually be doing routine screening of axilla in these patients so that we can triage them for doing sentinel node biopsy. And they also tend to have a higher disease extent on imaging compared to the clinical assessment. And some papers have found that they represent higher proportion of ER negativity and HER2 positivity. Nodal positivity actually definitely correlates with microinvasion, and larger size and palpability definitely correlates with upgrade at final pathology. So we actually should be doing adequate counseling of the patient so that the patients actually do not come to a shock when the final pathology mentions invasive or microinvasive component. And individual decision making has to be done in multidisciplinary tumor board to actually avoid under or over treatment of these patients. So with this, I would like to thank you for your kind attention. Now, I think we would like to take the questions later on, and I would actually like to invite Dr. Arun Goel for panel discussion. Dr. Arun Goel, and
Yes.
also to introduce our faculty members.
Thank you, Dr. Vaishali. We are going to discuss the management of DCIS along with our speakers, Dr. Mathur and Dr. Vedant. And we also have in the panel Dr. Shubham Jain, who is a senior consultant in surgical oncology in Max Saket with the interest in breast oncology. Dr. Madhvi Chandra, who is a senior consultant in radio diagnosis at Sir Gangaram Hospital and a very keen interest in the field of breast imaging. Dr. Shikha Haldar, who is a senior consultant in radiotherapy, radiation oncology at BLK Hospital, and Dr. Piyush Bajpayee, who is a medical oncologist at Manipal Hospital and who previously was working with us in the Max Institute of Cancer Care. So welcome all the panelists. We have 2 or 3 cases. So first patient, actually, I will just try to summarize. It's a 38 years premenopausal lady with a lump in the right breast along with nipple discharge, clinically a 5 centimeter lump. Mammography did not show a very clear-cut lump, but an area of architectural distortion. Ultrasound also showed a ill-defined hypoechoic area with a suspicious node, BIRAD 4B. This shows the difference in the tissue density between the 2 sides. So we can see here, this is the area of abnormality. Again, here on this side. Then she had a FNAC outside, which was suggestive of fibrocystic change. We did a MR mammography, which basically showed again area of architectural distortion, non-mass-like enhancement, washout type of curves, and an abnormal node, which was reported as likely involved. These are the MR images. We can see this area of abnormality here in the right breast. Core needle biopsy showed basically DCIS, clinging, solid and cribriform pattern, high nuclear grade, no necrosis, no evidence of invasion. She underwent mastectomy with sentinel lymph node biopsy. Frozen section sentinel nodes were negative. Final tumor size 6 centimeters. And it was pure DCIS, no invasive component, solid cribriform clinging pattern, high nuclear grade, stromal desmoplasia, sentinel nodes negative, all margins clear, ERPR negative. So now we will come to the issues here. Dr. Madhvi, yes. So I think Dr. Mathur also mentioned that, and Dr. Vedant, that imaging is a tricky issue when it comes to assessment of in ductal carcinoma in situ. So can you sort of highlight what is a good imaging approach? What imaging combination will give us a most accurate estimate of the extent of DCIS? And secondly, any imaging features when we should suspect that we might be dealing with a DCIS rather than an invasive cancer, or there is a non-invasive component?
So, well, 75% of all DCIS presents as calcifications, which all of you know. And there have been some studies which have tried to link the type of calcification with the grade of DCIS, but not successfully so far. Although the fine linear and fine linear branching, especially when in a ductal or segmental or linear distribution in the breast, those types of calcification are classically DCIS. Now, architectural distortion, unfortunately, some of it is seen with DCIS also, as Vaishali mentioned. And we know that there are masses and nipple discharge in DCIS also. So 75% is all calcification, 12% presents with masses, and the remaining 13% can present as architectural distortion or focal asymmetry. So those are the patterns that we see. And also on ultrasound, frequently we can pick up masses, which is very useful for us, because then we can simply go for an ultrasound guided biopsy. VAB is a better option than core needle, because we get a much larger sample and the chances of upgrade become lower. In fact, one of the trials that Dr. Vedant mentioned, the inclusion criteria is VAB. So the person has to have had a good VAB with entirely low-grade DCIS to be included in the surveillance follow-up.
So in terms of, let us say, a mammography shows a microcalcification, a core needle biopsy has been done, which shows DCIS. Would you recommend additional imaging for correctly defining the extent of the lesion?
Yes, absolutely, because MR is actually much more sensitive than mammography. Mammography picks up calcified DCIS, non-calcified DCIS to a certain extent can be picked up by ultrasound, but MR is currently the gold standard. About 96% sensitivity to DCIS. And the extent of disease is very nicely delineated, although there are studies that show that MR sometimes overestimates the extent of disease. So whenever we have a diagnosis of DCIS, we always would advise MR preoperatively.
Okay. And on MR, what would be a sort of accurate indicator of the extent of DCIS? Any specific features that you would like to highlight?
Non-mass enhancement is classically what we see. With DCIS, it can be of various types. It could be heterogeneous, linear, clumped, and ring type. This could be segmental in distribution. So it again, the distribution as well as the type of enhancement. Kinetics can be somewhat useful, although they're normally type 2. So there's a rapid wash-in and then followed by a plateau phase. It's not unlike invasive carcinoma, where there's a lot of neoangiogenesis and leaky vessels. It's not a rapid wash-in, rapid wash-out type 3 curve. So yeah, but MR is great for extent of disease.
Okay. And normally, if it is a screen detected or on a routine mammography, something has been found, how likely an ultrasound will find something which can be biopsied? What is the possibility? What percentage?
Say about 25 to 30% of them end up showing up, a finding either within the duct. Sometimes, as our resolution of ultrasound has become better and better, and with more experience with very high frequency probes, sometimes even if there's no mass, we can pick up tiny microcalcifications. And with tomosynthesis, we know the exact location of the duct. So it's become very easily possible to do a biopsy of that area and confirm calcification on a specimen radiograph, like the one that Dr. Mathur had shown in his slide. So we can confirm that we are in the correct area.
Dr. Mathur? Is Dr. Mathur there?
Yes, yes.
Dr. Mathur, let us say that VAB is not something which is routinely available, only very few centers have it. So short of VAB, what do you recommend, say, in terms of the size of needle, which is likely to give enough tissue for a more accurate diagnosis and a lesser possibility of upgrade later on?
Rather than the size, I think you people are the experts in that, but I would like to say that the size of the core is very important for us. We need at least 2 good cores, around 1 to 1.5 centimeters. Ideally, that should be a minimum kind of a material which should be available. It should not be fragmented, because once, especially in these DCIS kind of lesions, if a duct, if the fragmentation occurs at the level of those lesions, they become very difficult to interpret, because then you see half the duct and you don't know what's happening in the other half. So, and of course, so one is the adequacy of the biopsy, one is the artifactual fragmentation has to be avoided, and secondly, of course, the fixation and the cold ischemia time, etc. Standard recommendation apply to these lesions also, because after all, we might be requiring to do biomarkers in these also.
Yes. So, Dr. Madhvi, what size needle do you routinely use for biopsies?
For routine TrueCut cores, we use a 14 gauge.
14 gauge.
Yeah. Less than that is not recommended, because we do need nice solid cores, like Dr. Mathur has said. I mean, I don't want the pathologist ringing up and yelling at me. It's a very narrow core that doesn't really work, especially when we are dealing with DCIS. And we try and give them at least 5 cores.
Dr. Shubham, can I have you on? Say in your practice, what is the distribution of symptomatic versus asymptomatic or sort of routine health checkup detected DCIS? I wouldn't say screen detected, because we are not having screening as an approach in India. So patient has a health checkup versus symptomatic.
So screen detected DCIS or incidentally detected are still very less in what we routinely see. We still, if there is a DCIS, would be seeing more of palpable DCIS
Yes.
and therapeutic options accordingly. What I would also want to make a point is, though Dr. Chandras did mention that MRI does delineate DCIS very well, I think it depends on the clinical implication of what the patient is wanting from the diagnosis. So in cases where patient is opting for a mastectomy, probably we are still not going ahead with MRI in all those cases, even though
Yes.
it may be a DCIS.
But if you are going to do a conservation, you would do MRI as a routine.
Probably yes. Probably yes.
Even in a fatty breast.
So obviously, if the imaging, if in the dense breast, obviously the MRI helps a lot in way of imaging also. So for fatty breast, it's something that I'd weigh the pros and cons when discussing with the patient. But dense
Okay.
breast, definitely MRI would be
Okay.
recommended.
Dr. Vedant,
Yeah.
do you do a MRI whenever you are planning a conservation in DCIS?
No, not all patients.
Not
In
all
a fatty, in a
patients.
fatty breast, I would not do. In a
Okay.
fatty breast, we know that the lesion is very well circumscribed at one area. I would not do it.
Okay.
So,
And
Dr. Vedant, I'm sorry to interrupt.
please.
Would you not consider non-calcified DCIS at all? Because even in a fatty breast, there can be areas which are not picked up on mammo. And I mean, I'm primarily a mammographer and less an MR practitioner. But, like even in fatty breasts, we have seen that you get other areas of non-mass enhancement.
Yeah, but then in a very fatty breast, there are going to be some changes. You see non-mass-like enhancement on MRI in a large area, and you don't see on mammogram is a little unlikely. Very small percentage of patients, maybe very small percentage of patients.
Plus, usually, what I feel is generally these patients are hormone receptor sensitive and would be requiring
Yes.
some adjuvant therapy following treatment for the primary. So I'm not sure whether it makes any clinical relevance, honestly.
But having said that, it is a proven fact that MRI will show you a larger area as compared to mammogram in many of the patients. That's true. That's true.
Yeah, I think that always is there, whether it's for invasive cancers where when you're doing breast conservation. So that debate will always be there, whether MRI overdiagnosis leads to higher mastectomy rates and all. So I don't think it can be settled straight away. Now let's come to the next fact. Say this patient had finally a tumor which was 6 or 6.5 centimeters. We did a mastectomy. Would you be comfortable offering a conservation in a large DCIS? Vedant and Shubham, both of you, yeah.
So obviously the size of the lump was quite extensive, 6 centimeters. So there would be some need for a oncoplastic replacement reconstruction that would be required in such a patient. So if the patient is keen, I think that's fair enough an option, provided we can give good cosmetic outcomes.
Okay.
Yeah, I agree with Dr. Shubham.
So generally, you would believe that excision of the palpable lesion would be sufficient combined with the radiation for taking care of the local control.
Yes, if that is the only disease, and if we have ruled out any other disease by whatever modality is needed by imaging.
And another concern is like in large lumps, the possibility of upgrade to a microinvasive or an invasive tumor is it's significant. Let us say even if it is 10, 15, or 20%. Would you consider a frozen section to look at a possibility of invasive component or not?
Most of the time, we would end up doing a frozen section. The honest confession is yes, we end up doing a frozen section, but for such a large one, you are anyways going to do a sentinel node biopsy, so it may not really change your management.
Plus, the frozen section is done primarily for the margins and not for identifying any invasive focus.
Yeah, definitely for margins. So, Dr. Mathur, can you make a comment about the role of frozen section for margin assessment in an in situ cancer? What do you believe as a pathologist, reliability of frozen section?
No, I think it's not something which is very often done here, because at least in my institutional practice, They do a lot of BCS for DCIS and early kind of lesions, but they never send those for frozen. In fact, what they do is they send the specimen intact. We ink the margin, take extensive margin sampling while grossing. And another thing with some of the surgeons, especially Dr. Dev likes to do this, is he takes cavity shave margins and sends separately. Those are margins sent by the surgeon. So that I find very helpful, and it kind of increases the level of confidence regarding the negativity of the margin and evaluation. Because I find if it is sent for frozen, the interpretation becomes very difficult, because frozen section is not the ideal section to interpret or evaluate the lesion as like a DCIS. So I think it's best avoided in this scenario. And regarding the microinvasion part, the earlier discussion which was taking place, I would like to say that when there is such an extensive DCIS and such a large lesion, your index of suspicion for a microinvasive carcinoma should be very high. And in this context, the pathologist has to sample the lesion extensively, which we call as serial sequential sectioning of the specimen. Because see, they say that in high-grade DCIS with lymph node involvement, there's probably some focus which you have missed. So that is not truly a high-grade DCIS. It's some DCIS where a invasive focus has been missed. Yeah, which is usually a micro-invasive one.
So
Dr.
normally,
Goel,
how many?
Your question was for frozen section for diagnosis or for margins?
No, I think basically both elements are involved. One was look for a possibility of upgrade, and second was about margins. So right now it was about margins. Whether an in situ tumor at margins can be picked up easily on frozen section or not. I think there is a difference in practice in terms of we do frozen section for margins, and we generally believe that if it can reduce the resurgery rate even by half, so that would be good enough for us, because our patients are not very comfortable with resurgery and the burden. So in a setup like AIMS, the burden of pathological work would be much higher on the pathology. So those issues will definitely come in consideration.
Yes.
So Dr. Mathur, do you say that, like, what would be the level at which you would say multiple cuts, spacing between different levels to have an optimal assessment?
Yeah, so if it's a small DCIS, you can kind of take the entire in 1 or 2 blocks and kind of have serial sectioning in that itself. And if it's a larger lesion like that, then we do sequential sectioning, means we go through at say a millimeter or 2 millimeter interval. We take one, make a block out of that part of the tissue and kind of have deeper sections done on that. So those are the ways in which you can ensure that you are trying to pick up the possibility as much as feasible, I mean, practically feasible.
So like if in a 6 centimeter specimen we do at 2 millimeters, there'll be something like 30 steps.
Yeah, sometimes there may be lesions, like if you are kind of you're supposed to actually look at and identify any such focus. So if it requires that kind of sampling, it must be done.
Okay. I think now we'll ask Dr. Piyush.
Yes.
Dr. Piyush, can you hear me?
Yes, sir.
Oh, this particular case was actually at our pathologist did not find any invasive component, but it was a 6+ centimeter tumor and ERPR negative. Now the question was about, one was a HER2 testing. So what is your practice? Do you recommend HER2 testing in every DCIS?
I believe HER2 new testing right now is more in a investigative this thing, rather than an sort of a practice change or change in decision making for the treatment. NSABP 43 trial, where HER2 new patients were taken concurrent with the RT trastuzumab, 2 cycles were given, has turned out to be a negative trial. So for now, the decision of HER2 new positivity does not change any therapeutic decision. As regards to this patient, if the core biopsy has shown ER negativity, and we are sure that this core biopsy, all the fixation and everything was good. So I think so we don't go by giving further tamoxifen or any further treatment.
Let me ask you about tamoxifen or endocrine therapy. See, one of the risks in situ cancer is like it is also a marker of a higher risk of disease even on the contralateral side. So something like a preventive endocrine therapy, do you think that merits?
Probably this could be a discussion. I mean, if there is a family history, if we are looking for some BRCA positivity sort of situation, then probably it could merit a discussion. But I don't think so. Looking at the side effects of tamoxifen, endometrial carcinoma, those discussions happening, thromboembolism, I don't think so. It would be really worthwhile too.
And if I
Dr.
change,
Arun, also I'd like to make a point. There was a trial NSABP B43 that was done to assess whether testing for HER2 positive and treating with HER2 positive directed therapy is it cost effective really for DCIS, and the result for that was negative. So probably that's another reason that there is no merit in testing for that.
Yeah, absolutely. Dr. Piyush, let me change the clinical situation. Suppose this patient showed microinvasion. So we have a 6 centimeter tumor with 3-4 areas of microinvasion. Would that change your decision in any way?
Microinvasion being there, well, then it's still a triple negative.
Yes,
it's still a ER negative disease pattern. I mean, still it would not if the microinvasive component is just there. So,
and if we find a sentinel node which shows, let us say, a micrometastasis. So I'm going one step further. The pathologist did not find microinvasion or found microinvasion, and there is a sentinel node with micrometastasis. Then anything?
Again, I mean, it's if we are entirely falling back on the pathologist report, we are very sure that it is the true microinvasion. I don't think so. It really does change immediately. But if in case there are any gaps in information, then probably yes, we can have a discussion. This is what I can say. Yes.
Okay, so that's wonderful. Before I go to the next case, I had just 1 or 2 questions for Dr. Mathur. Dr. Mathur, there was a discussion about 2 ductal spaces as a sort of discrimination between ADH and DCIS. And then there was one slide in which you mentioned 3 spaces in reference to ADH.
No, 3 spaces. No, I just tried to show that an ADH in a you would same the low grade DCIS and ADH have similar morphology. The point I was emphasizing on that slide was that if you have more than 2 ducts involved, the same appearing lesion would be upgraded to a low grade DCIS. That's what I said.
So that more than 2 spaces have to be in contiguity?
Yeah.
So if they are separated
usually in contiguity doesn't mean that they will be separated by normal breast trauma, but it's in the same biopsy. That means taken from the same area.
Yeah. Okay. And another thing was, like you said, usual ductal hyperplasia, the nuclei are sort of more polymorphic.
Yes.
Then we have low grade DCIS where they become monomorphic.
Yes.
And then high grade DCIS where there again is polymorphism. So how this?
So the high grade DCIS, the pleomorphism, it's more like a better word to use for that is pleomorphism, because those are bad nuclei. That means there are very much enlarged and variable in size. So here, their chromatin features are very different. They are hyperchromatic nuclei, prominent nucleoli. So they are like malignant cells. So those are like same cells as invasive carcinoma, grade 2 or 3.
Okay.
Whereas the kind of polymorphism in UDH, which I told, they are not cancer cells. So they are benign cells showing some variation in size. That's all. They don't have hyperchromasia or prominence of nuclei, mitotic activity, and things like that.
We'll quickly go to the next case. Here again, it is a 37-year lady presented with a nipple discharge from right side. Mother of 3-year-old twins, had been treated for infertility, was having regularly ultrasound both breasts for lumps, which were previous FNAC showed fibroadenoma. So there was a small firm area and adjacent to the nipple, just subareolar and the periphery of areola, plus a lump in the opposite breast. She had tomosynthesis, which showed a 4B lesion in the right breast, about 2.5 centimeter hypotenuse area, and a lesion in the left breast, which was 4A. Ultrasound also was done. This shows the area of abnormality on the right breast with little bit of microcalcification here. Then MR mammography showed an intraductal lesion with type 2 kinetics, ductal wall enhancement, intraductal papilloma with moderate suspicion of malignancy, PIRAD 4B, and a lesion on the left breast, PIRAD 4A, type 2 kinetics. Dr. Madhvi, would you like to make any comments or?
So on these mammograms, what I can basically see in the area which was marked on the physical exam diagram is a little bit of architectural distortion. You have this little bit of pulling in right in the retroareolar region. And that calcification there, I mean, while I might want a magnified view for that.
Yeah, absolutely, I agree.
Yeah. It might be coarse heterogeneous, but on this it's looking almost like acinar. So I would definitely want to look through the tomo and a map view for that calcification.
These are the MR films showing the area of abnormality on the right side.
So,
yeah, Dr. Madhvi, would you like to add?
So there's this, there appears to be this large duct which is involved with almost an intraductal papillary sort of mass. Like I said, I'm not a primary MR reader.
Yeah, I know, I understand.
But, that segment seems to be involved for, especially on the MIP image. There seems to be a long segment that's involved.
Yeah. So basically, patient had ultrasound-guided cord-needle biopsy, which showed a intraductal papillary neoplasm with epithelial hyperplasia, and the left side was a benign fibroepithelial lesion, query fibroadenoma, query benign phyllodes. So this is the ultrasound-guided biopsy being done. So it was discussed whether patient should undergo VAB surgery, but ultimately the patient underwent surgery. So right duct complex excision with wide local excision of the palpable lesion and wide local excision of the left breast lump. So let me ask, say, Dr. Vedant and Dr. Shubham, what would be your approach in this situation? Would you differ or?
So the option that you gave the patient are perfectly fine. It is VAB or surgery, and patient probably chose surgery, which is fine.
Yeah.
VAB has a very low upgradation rate if they have completely excised the tumor, nearly completely. So the upgradation rates are nearly zero, not zero, but nearly there. And I agree with the surgery that you have done. Wide local excision also on the left side. Okay, possibly if you go in and enucleate it may also be nice, but then you had a suspicion of phyllodes also, so wide excision on the left side. Wide excision on the left side is also okay. And with such a small tumor, even if you go wide, you are not going to cause cosmetic deformity.
Dr. Shubham, let us say if there is a suspicion of phyllodes on a cord-needle biopsy, would you be happy offering VAB in such a case or not?
No, I wouldn't be comfortable offering VAB if there is a suspicion of a phyllodes.
Okay. Dr. Mathur?
Yes, sir.
Say, cord-needle biopsy specimen, how difficult it is to differentiate between a well-differentiated, sort of a low-grade phyllodes versus a fibroadenoma? Is there any way to sort of make the differentiation?
Yes, so it's quite variable. You see, there are some phylloides tumor which are benign phylloides tumor if you're talking about vis-a-vis fibroadenoma. There is a lot of increased stromal predominance. That is one feature.
Yeah.
If it is conveniently there, it is easier. And then the stroma, if it shows more than an occasional mitosis, that really kind of makes us suspect or think. And of course, clinically, patient presenting with a larger lesion, slightly larger lesion, older age. So all these, putting all these three together, we often raise the suspicion of a phylloides tumor on a core needle biopsy. Now, going beyond that, whether to characterize it as borderline versus benign, that becomes increasingly more difficult. And unless, of course, it has frank malignant features in the stroma where we can think of at least possibility of a malignant phylloides. Yeah.
Okay. So then we come to the pathology report. So left was a benign phyllodes tumor, 2 centimeters, all margins free. Right one is the issue which needs to be debated. It was an intraductal papilloma with DCIS. Total specimen size 1.2 centimeters. Low to intermediate nuclear grade, no necrosis, all margins free. Nipple core was also done at that time, which showed benign epithelial hyperplasia. So closest margin was anterior, which was 5 mm, and strong ER positive. So before going any further, I think we will have Dr. Shikha Haldar. Dr. Shikha has been waiting very patiently. Dr. Shikha.
Yeah, hi.
Hi.
Yeah, I knew
this
you
is
were
the situation, yeah.
Yeah. So I knew you were coming towards radiation. I just missed the point. I think what was her age?
Age is 37.
37. Well, there are a few points which is, she has a low or intermediate grade tumor and a very small tumor. But margin, usually if you want to, this is like we are going towards whether we can do without radiation.
Yes,
but there are
yes.
2 points which is against, that is, one is her age, she is 37, and we would like a margin of 1 centimeter as a radiation oncologist. If she doesn't want radiation, she has to be counseled well that there is a, even in the low grade or this thing, there is a small benefit with radiation. If the choice was given to me, I would definitely like to radiate her, give radiation. Maybe not add boost, but definitely give her 5 weeks of radiation to the whole breast.
And you would give whole breast radiation. What do you feel is the role of APBI in sort of small DCIS?
There are few trials. There are actually 2 trials, but with very small numbers. They have shown a very good result. There is no difference. But then we need, it is about 3 to 5 years follow-up. So which is not very long follow-up. I think we have to wait for the longer follow-up results to go for APBI. I think we can fit in the, the ASTRO guidelines where we give APBI in invasive tumors. Maybe if we can fit that criteria like older age group and single foci, and then maybe and also take into account patients. We have to put it in front of patients. This is the result, and whether she would like to go for APBI. Like if she has other. Yes.
Would the ER status affect your decision about offering radiation or using APBI?
No, APBI is basically they have used in like older age group, maybe intermediate type. It is not, most DCISs are positive, ER positive, but definitely with ER positivity and radiation in DCIS has definitely shown a better loco-regional control. So if the patient has undergone BCS, then radiation, ER positivity is not a criteria to decide whether to give radiation or not. It is rather the low grade or intermediate grade, age group, comorbidity, and patients, refusal to take treatment is the deciding factor rather than ER positivity.
Okay. I would just like a comment from Dr. Vedant and Dr. Shubham. Definitely, I believe in DCIS surgeons do come in the discussion for adjuvant therapy decisions. What would you sort of incline towards, radiation or no radiation, or let the patient decide?
With the current guidelines, the patient ideally should be going for radiation.
Okay.
I agree with
and adjuvant hormone therapy as well.
definitely the hormone therapy part we'll discuss about it was right now. Actually, we had a lot of debate about this patient in view of the low grade and small. So then ultimately the patient went to AIMS also for opinion. So there she was sort of given not very strongly in favor of radiation. So she has opted not to go for radiation. That is what has happened. Patient has been treated just a few months ago. So only time will tell what happens.
Yeah, so that's a fair choice. That's a fair choice. And it's an
Yeah.
informed choice. So that's fine.
It's an informed choice, absolutely.
So
Dr.
another angle coming to this now, if the patient was treated during the COVID and the lockdown, then definitely adding radiation there and 5 weeks of hospital visit has a different implication.
Yeah, absolutely, that I understand.
Right.
So Dr. Piyush.
Yes, sir.
So we have a 37 years patient with strong ER positivity. So what would you offer to her?
Yes, of course. I mean, tamoxifen would be there. Tamoxifen would be offered since because of strong ER positivity. We are still evolving on data whether just to stop after surgery over there.
Yeah. So in terms of what will be the duration of tamoxifen, and would you sort of use the standard dose of 20 milligrams? So do you think such a patient could also be managed with a low dose of tamoxifen, which has been discussed in some studies?
Some trials of 5 milligrams are there, but then most of the trials, the data set is on 20 milligram, and we really do not know that lowering the dose would offset the side effects which we are doing. I mean, for whatever the worth we get. So 20 milligram would be my dose for 5 years.
For 5 years. And if the patient is postmenopausal, would you prefer AIs?
If the patient is postmenopausal and is less than 60 years, AI has a slight benefit over tamoxifen in terms of ipsilateral and contralateral recurrences. So yes, AI would be preferred, but AI is not easy to take, and therefore tamoxifen can always be looked upon if AI is not being tolerated because of bony pains or other issues.
Dr. Vedant, you wanted to add something? Or no?
Yeah, regarding the low dose, so there is a randomized trial, but unfortunately they compared 5 milligram with a placebo, not with 20 milligrams.
Not with 20.
But they did prove that the side effects were less. The rate of endometrial cancer and the rate of venous thromboembolism was 2.5 times less as compared to 20 milligram studies.
Okay.
So there is an option of 5 milligram per day or 10 milligram alternate days. That is what they used, I guess, if I remember correctly.
Okay. Yeah. Dr. Vaishali, are there any important questions on the chat that we need to ask?
Yes, sir. Yes, sir. There are. Before actually we move to the chat box questions, I would actually want to ask Dr. Vedant and Dr. Shubham as well as Dr. Madhvi here in this particular patient, because this lady, as Dr. Shubham rightly pointed out, that because of COVID, she was very apprehensive in the first place to come to the hospital with her symptoms. But when it was a tough time convincing her to undergo surgery, and then at a later date when there was a question of radiotherapy, she obviously we asked her to take a second opinion, and when it was endorsed by AIMS that yes, no, radiation can also be a treatment option for her, she actually jumped to that. The other important question which she asked me was, because she is relatively young and has 2 young children, she was actually very worried about her follow-up. So I would like Dr. Vedant or Dr. Shubham to take this call as to how frequently should we be doing her imaging and what imaging, because we have looked at her mammogram and we've seen that it is definitely a relatively dense breast. So how frequently would you recommend imaging, and how which imaging would you be like would you like to do for her?
So this lady would not need really any closer surveillance than the follow-up that we do otherwise for a breast conservation. Dense breast means and you did MRI in the first place, right?
Yes.
Before surgery.
Yeah.
So I would recommend MRI, annual MRI for her apart from mammogram.
Right. Dr. Shubham?
Probably I would be happier with an ultrasound itself with the dense breast for now, and later, if the density goes less, probably we could switch to mammography.
Okay. Madhvi ma'am?
Yeah, so Dr. Shubham, I disagree with the ultrasound only follow-up if that was what you were recommending, because that is simply not good enough. The sensitivity is very, very low. So what Dr. Vedant suggested, mammography and MR is good. And, you know, any patient with a personal history of breast cancer now qualifies as a higher risk. So we would probably put her on alternating mammography and MR like we would any high risk patient. You know, we have at 6 months from surgery or from the cessation of radiotherapy. She's not having radio, sorry. So at 6 months from surgery, we have the first investigation, which would be a mammo, and then follow 6 months later with an MR and alternate the mammo and MR like that.
So Dr. Madhvi, we also ask for alternating mammo and MR 6 monthly. But how often do you see that we need to do MR based on some mammo findings done? Because mammo is done alone and MR is done alone at an interval of 6 months. So how often do you feel that with mammogram done alone, you need to do MR again at 6 months? At the same time, I mean.
At the same time.
Yeah.
So, I mean, I don't have data, but there are some patients in which we have changes that happen. And we do need to add an MR simultaneously, and that changes the follow-up protocol, obviously, for the coming year. If she goes to surgery or biopsy, then that modifies the follow-up, depending on the assessment, really. If we by RADS 4 or 5.
Also, the reason I was suggesting for an ultrasound was, though, I was under the impression that she's a 37-year-old, less than 40 years, and was having dense breast on the initial evaluation. So would doing a mammography in the follow-up be of any benefit, or
yes,
rather?
In fact, we have now tomosynthesis widely available, and dense breasts, you know, like we are dealing with DCIS here. We have possible calcium in the first pathology. It's mammography is definitely something over 30. Any diagnostic any diagnostic patient, especially in someone with a proven history of cancer, you have to do a mammogram. There's no getting away from it. Whether dense or not dense, we will pick up findings, and we are likely to pick them up much earlier, and we are able to target our ultrasounds to areas. And, you know, having both, I mean, anybody who does a mammogram will add an ultrasound in any case, any good center. They're not going to leave out the ultrasound. That's considered part and parcel of the mammogram. So the mammogram doesn't get left out. The ultrasound is part of it, and the MR, of course, follows later.
So I'm sure a combination of mammo, MRI, and of course, in case if some suspicious finding is actually seen on any of these, then ultrasound guided, a second look ultrasound will definitely help us to biopsy that area. So I think now we have to move on to you know, some questions. So Dr. Neha actually wants to know about margin revisions. So in case of DCIS, when would you be willing to go ahead with margin revision, and when would you like to leave the margins, like with the focal margins or gross or whatever? So what is your take on margin revisions in DCIS, Dr. Vedant?
So for DCIS, any positivity, you have to revise margin, definitely. Less than 2 mm margin for a high grade DCIS, for a high risk DCIS, ideally you should revise, but you can choose to wait. But any focal positive or more than focal positive has to be ideally revised, unless the patient just doesn't agree for revision.
Right. And there was one question about the conservation in large palpable DCIS. There were some comments by Dr. Rajiv that 6 centimeter tumor DCI should not be actually being planned for breast conservation surgery. Would you like to comment on BCS in these patients or extreme oncoplasty? Would you like to comment? Because there have been some studies or some papers which have actually incorporated patients with very large DCIS and have been managed with extreme oncoplasty. Would you like to comment on that?
Yeah, so it depends on the desire of the patient also. And as you said, extreme oncoplasty, I think extreme oncoplasty should be used with extreme caution. Well-selected patients, motivated patients, and strongly desirous of breast conservation, they should understand. And then I think we can offer, there is no problem in that.
Right. Thank you. This is one question from Dr. Rajiv about the use of trastuzumab or HER2 positivity. So he has asked about one scenario wherein a patient who has undergone mastectomy for DCIS and has been found to have a 3 millimeter focus of invasion, and she is HER2 positive. So although Dr. Piyush has actually left, would you like to comment about the treatment, the HER2 directed treatment for these patients?
For a microinvasive, I don't think we have any data. And I remember we had one patient with microinvasion, large, very large DCIS, almost 9 centimeters. Microinvasion was HER2 positive. We discussed with our medical oncologist, I was in Fortis that time, and Dr. Rena decided not to give anything. So for a microinvasion, small disease, HER2 positive, I don't think there is any data to give trastuzumab.
Can I add a point here?
Yeah, sure.
Yes.
Only thing is, like, technically, if it is 3 mm focus of invasion, it would be classified
that's
as
more than
T1A.
microinvasion. That's more than microinvasion.
But see, there now all the medical oncologists today quote about the APT trial when it comes to small HER2 positive cancers, and APT trial has shown excellent outcomes over up to 7 years of follow-up. But again, the question is that T1A is a very low risk category, and I believe that we should seriously debate whether these patients derive any benefit from addition of trastuzumab.
So mostly I agree, matlab less than 0.5 centimeters if the focus is there, may not benefit from any HER2 directed treatment.
Right. So there was a lot of debate in. Yes, sir.
Dr. Soni, Dr. Naresh Soni is there. He wants to say something. Look, Soni, are you there?
Yeah. I was asking from Vedant, yes, when patients choose for the bilateral mastectomy in DCIS,
yes,
whether there is a genetic, what is the genetic status of these patients, like BRCA, or you are doing that BRCA? Or...
Yeah, so I have not yet done a bilateral mastectomy for DCIS. I've done it for IDC. We ask if they come into the criteria of genetic counseling and testing, we do ask them to go ahead with it. Some of them would not like to go ahead with it. Some of them would go ahead with it. Having BRCA negative also will ask for bilateral mastectomy. And such situations, we do extensive counseling. We do a rediscussion in tumor board, take an approval from the board, and then go ahead with bilateral mastectomy. I've done it only twice in such a patient.
Can we ask Dr. Sandeep Mathur, if we have, say, a triple negative DCIS, say, at the age of 35 or 40, is there a correlation with the BRCA mutations? Is Dr. Mathur there?
Yeah, I'm there. But yeah, I don't think that having a triple negative, because many a times these high-grade DCIS, they are triple negative or HER2 new only positive. So every such case, if you are going to suspect, I don't think it's the right approach.
So, Dr. Vaishali, any more questions, or is that?
Yes, actually, there was a question about what percentage of DCIS is ER positive, estrogen receptor positive. This is for Dr. Sandeep.
Well, it depends upon the type of DCIS. As I said, the low-grade DCIS, they are almost always ER positive. So the HER2 new positivity may vary. That's very rare, but ER is almost always positive. And while the high grade, amongst the high grade ones, around 25 to 30, I would see in our practice would be ER positive.
Yeah.
But
So
if
there
you,
have been,
that depends again on what level you consider positivity. If you just count as more than 1%, that percentage will definitely be higher than what I just said.
right, right. So I mean, there is a variation in ER positivity reported in different studies, and again it depends on whether it is a screen detected, as Dr. Sandeep has already mentioned that majority of these low grade screen detected are almost always ER positive. Then there was a question about, there have been some discussion about MRI. There was one question about whether the patient needs to always undergo MRI before breast conservation is planned in palpable DCIS, especially in women who are actually claustrophobic and do not want to undergo MRI. So can they not be offered breast conservation surgery if they are diagnosed with a DCIS on needle biopsy? Dr. Vedant or Dr. Shubham?
So it depends on the kind of surgery. Definitely, as I said initially also, if the patient is keen on a breast conservation, I would prefer, but I would not eliminate the option of a breast conservation if the patient cannot get a MRI done. Obviously, the adjuvant treatment, if the patient is strongly ER positive, or the radiotherapy that would be needed post the surgery, would take care of some component that may be missed out in the absence of an MRI.
Yes. Yeah. Dr. Vedant, would you like to say something?
Yeah, so we have actually
You have already
discussed at length in the chat about MRI. So
right,
yeah.
right. I think I'm sure we have covered almost all the aspects of DCIS in today's discussion, in talks as well as in the panel discussion. So over to you, Dr. Goel, for parting comments.
Thank you, Dr. Vaishali. We have discussed and tried to cover as much as possible. As Dr. Mathur was also saying, we can go on and on. It can never be completely covered. So we'll have to ultimately close it. I would like to thank all the faculty, Dr. Mathur, Dr. Vedant, Dr. Shubham, Dr. Shikha, Dr. Piyush, and Dr. Madhvi for taking time off, and for everybody who joined in for the program. It's basically your joining in that makes it worthwhile for us to plan something like this on a regular basis. So thank you once again, and looking forward to seeing you again in the next program. Thank you.
Thank you all, and good night.
Thank you.
Thank you.
Thank you, Ji. Thank you. Bye-bye.
Thank you very much.
Bye. Bye.